the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have some housekeeping remarks. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone for CME attendance purposes. Please put that in the chat box. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. Your comments are very important to our planning committee. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Kemble has disclosed that she has no relationships with commercial supporters. It's my pleasure to welcome our speaker, Dr. Sarah Kemble. She received her MD degree at UCSF, then completed a Med-Peds residency at UCLA and an infectious disease fellowship at Rush University in Chicago. After serving as medical director for the communicable disease program at Chicago Department of Health for 4 years, she came to Hawaii in March 2019 and has served as the deputy state epidemiologist at the Hawaii Department of Health and recently stepped up as the acting chief of the Disease Outbreak Control Division. Today, she will be talking about a very important topic, accurate reporting of COVID-19 deaths. We know she is really busy managing the pandemic, and so we're really honored that she's sparing the time to talk to us today. Welcome, Dr. Kemble.
Thank you. Okay, so today I will be talking about COVID-19 death reporting in Hawaii. Next slide, please. So there's several objectives to the talk today. One is to understand how COVID-19 related deaths are reported by the Hawaii Department of Health and how they're reported to the Hawaii Department of Health. Another is to be familiar with the various sources of data on COVID-19 deaths in Hawaii and nationally, including vital statistics and the National Healthcare Safety Network. And the third is to accurately complete a death certificate for a person who died with COVID-19. Next slide, please. I have no disclosures. Next slide. So first I want to talk a little bit, open with some slides on data on COVID-19 deaths in Hawaii. I'll give the caveat that all of these data are preliminary and may be updated as more information becomes available, but they provide a snapshot of what we can learn about deaths in Hawaii from the data reported to the health department. Next slide, please. So on our website, at the DocD website, there are a number of interactive visualizations that you can use and go to find more information about COVID-19 cases. This is one that looks at age and outcomes and is probably the best representation to see what the severity of disease is in different age groups and how many deaths are being reported by age category. So as seen in many other parts of the country, the patterns are familiar. There are many cases in the younger age groups, but they tend to be less severe. We have 0 hospitalizations, or perhaps it might be too small to see. There might be 1 hospitalization in the 0 to 17-year age group. But when you get into the next level up, 18 to 29 years, you begin to see a few. But it's not until about 50 that we begin to see a more substantial level of hospitalization and deaths. By the time we get up to the 70+ age range, we're seeing in the range of 40 to over 50% severe outcomes of hospitalization or death. Next slide, please. This is a table to show the where deaths have occurred over time in Hawaii. So first the breakdown by month, and you can see this tracks fairly closely with the case numbers that we've seen over time. So in April, we had a rise in death reporting, a small rise that settled down into May and June as case counts fell again. And then moving into August and September, we saw a substantial increase in number of deaths reported as the case rates rose very high. In October, we're now seeing a plateau, a decrease in deaths being reported. Of course, there is some lag for this month. The month is not completed yet, and deaths do take time to be reported into our system. So the October data need to be taken with a grain of salt. In terms of where deaths are occurring, they do track with the relative population size of the different, just still on the last slide. In terms of county of diagnosis for the deaths, they do track largely with the population size of our counties. So the most deaths are being reported from Honolulu County. Next slide, please. And this slide shows where was the location of death for those that are reported as COVID-19 related in Hawaii. And this is since March of 2020. The vast majority of deaths in Hawaii are occurring in a hospital or emergency department, and most of that category is hospitalized patients. There are very few who died in the emergency department. This is disproportionate to the number of cases that were identified from settings outside of the hospital, including long-term care. So you can see there's only 4% here that were documented as having died in a long-term care facility or group home. But we do know there are more deaths who that are associated with residents of long-term care facilities or group homes, but were transferred subsequently to a hospital for further care. And I think that's one of the things that the geriatric community is very acutely aware of, that we've had some struggles for finding appropriate placement in care for patients who may have been in a long-term care setting, but once they become COVID positive, providing adequate staffing and care for those patients can be difficult. So sometimes the transfers are related to those underlying issues rather than strictly by medical need. There are also some deaths reported from home settings and a few that are medically unattended. Next slide. So this is a visualization to show breakdowns by age, race, underlying medical conditions, gender, and county for, this was updated a little bit earlier than the last slide, so this is a total of 182 deaths represented here. And as predicted, the older age groups bear the most burden of the deaths. Race is also an important factor. We're seeing higher numbers of deaths among our Pacific Islander communities, but also among Japanese and Filipino communities as well. These numbers are raw numbers, so these aren't a rate, but it does give a general sense of the case counts and where deaths are occurring. In terms of underlying medical conditions, the vast majority of those who died had at least one documented underlying condition. This runs the gamut from diabetes alone to multiple comorbidities. And those are data that we are attempting to clean up and be able to present more clearly going forward. But at this point, we basically have whether there were comorbidities noted or not. In terms of gender, as seen nationally, there are a higher preponderance of males among the deaths than females. And as mentioned before, Honolulu County has been where the majority of the deaths have occurred. Next slide. So how do we receive this information to populate the data in these charts? There are numerous sources of reporting for COVID deaths in Hawaii, and it starts with case reporting. Sometimes we do receive a case report of a person who has already died directly from a medical provider. We may receive a case report of a person who is critically ill and then become aware of the death later. But the medical provider reporting remains probably the most important arm of reporting to DOH. There also is reporting from infection preventionists within hospital or long-term care settings, and they will let us know if they are aware of a COVID positive patient who has died, and that's one way that we can mark the deaths. We also have regular communication with the medical examiners, and this provides us information on deaths as well. There are some deaths that are first brought to our attention by the medical examiner. And then there are deaths that are detected through the case monitoring that the Department of Health is performing. But as you can see, all of these sources of information can be a little bit hit or miss depending on whether someone remembers to notify us of the death. The case reporting is immediately reportable, but often the additional information about what happens to that person, whether they become hospitalized and whether they die, is slower to come and filter through to the department. So this is a lot of what accounts for the lag in death reporting. There are a couple other sources of data that can provide information on deaths. One is the National Healthcare Safety Network, and another is the Electronic Death Registry System. And I will talk a little bit more about those two later. Next slide, please. So on the note of reporting from providers, these are important numbers for all providers to know. If you become aware of a case of COVID-19, it is reportable to the Department of Health at any of these numbers on each island or after hours through Physicians Exchange. If you do learn of a death in a COVID-19 positive person, that is something also we appreciate getting reports about so that we can update our case data. Next slide, please. So what is this slide? This is a snapshot of, if you go to the CMS website, you can find a map of the entire United States, and you can drill down to any part of the United States and hover over these little orange dots and get information on what each nursing home is reporting to the National Healthcare Safety Network. So the numbers that you see, this is just an example from Honolulu, but the numbers that you see are what are reported into NHSN by the nursing home staff. Next slide, please. So these data come from the National Healthcare Safety Network. NHSN is a surveillance system established by CDC to track healthcare-related infections and outcomes. So many are familiar with NHSN for reporting of things like line infections or urinary tract infections. But with the advent of COVID, NHSN has also set up a long-term care facility COVID-19 module. So this is a screenshot of the CDC website where you can find more information about the NHSN module if you're not familiar with it already. The module contains information about how to report both cases of COVID-19 as well as deaths. Next slide, please. This is an example from one of the NHSN training slide decks for how to complete their module. And this is the screen that shows resident impact, the resident impact pathway. There's 4 pathways of reporting in the module. So for resident impact, they're asking about admissions, residents confirmed with a new laboratory positive COVID-19 test, residents with suspected COVID-19 based on symptoms or exposure, total deaths, which is all residents who've died in the facility or at another location, and then COVID-19 deaths. Note that the way that NHSN defines COVID-19 deaths is any resident with suspected or laboratory positive COVID-19 who died in the facility or at another location. It's pretty broad, and it actually differs from how the Department of Health counts COVID-19 related deaths on our website. We count deaths that have been determined to be potentially COVID-19 related based on the death certificate. So the NHSN reporting is not tied to that determination, but the state level reporting is. So this begins to unravel some of the differences you may see between death counts reported in different places. Next slide, please. So let's talk about COVID-19 death reporting at the state and national level. Next slide. So these are some slides that were adapted from the National Center for Health Statistics, and some points that are made on the NCHS website are the importance of death reporting for the purposes of surveillance, developing policy, and for research. Next slide, please. So the data provided to NCHS include both provisional death counts and COVID-19 related counts. The provisional death counts deliver the most complete and accurate picture of lives lost to COVID-19. They are based on death certificates, which are the most reliable source of data and contain information not available anywhere else, including comorbid conditions, race and ethnicity, and place of death. So the National Center for Health Statistics uses incoming data from the death certificates to produce their provisional death counts. That includes deaths occurring within the 50 states and the District of Columbia. NCHS also provides summaries that examine deaths in specific categories and in greater geographic detail, such as deaths by county, by race, and Hispanic origin. And the COVID-19 deaths are identified using a new ICD-10 code. This is a death that is coded as U07.1. And that can occur in cases with or without laboratory confirmation. So it can include probable cause of death. Next slide. This is a table. So basically these statistics can be found on the NCHS website. And what I've done here is just pull out the latest update for Hawaii and nationally, last updated October 16th. So one thing you'll note, next slide please, is the difference in the counts for Hawaii from what you just saw in the state count, which is 186 as of yesterday. So there are differences in how the deaths get tallied. Some of this may be due to jurisdictional reporting differences. So I believe NCHS is counting deaths for all Hawaii residents, regardless of where they were diagnosed, whereas state of Hawaii is only reporting for residents diagnosed within the state. We aren't reporting out the deaths for those who died outside of Hawaii. There's also differences in lag times in terms of how the data flows to NCHS. We have worked here within DOH to work with our Office of Health Monitoring to try to get timely information on deaths that are occurring. But some lags occur due to delays in death reporting to OHSMB, and is also for the ability to pull that information, which often comes in batches. So that work between departments is still very manual and paper-based. So one solution we're looking at is to set up direct electronic feed for the death reporting so that it would pass between our programs and closer to real time. Next slide. NCHS provides a number of useful statistics. You can see here excess mortality in the United States over the weeks since the epidemic started. And you'll notice a blip back in January related to a bad flu season. This is all-cause deaths, not specific to COVID-19. And then it's been since April of this year when COVID hit that you really see this spike in deaths throughout the US and the trends that have evolved over time. Next slide. For Hawaii, we also see slightly different seasonal patterns than the rest of the United States, but you can also see where the red crosses are, times when we have had flu peaks and flu-related death reporting. And then a much flatter curve for deaths overall than nationally, but with some recent red crosses here in October, late September and October. Next slide, please. So let's talk a little bit about certifying deaths. There are a few key points. If COVID-19 is determined to be a cause of death, it should be reported on the death certificate. And it's important when reporting COVID-19 as a cause of death to use standard WHO terminology, such as coronavirus disease 2019 or COVID-19. It's also required to report pre-existing conditions that contributed to the death in Part 2 of the death certificate. Next slide. So how does death certificate reporting work? When a person dies, the cause of death is determined by the certifier, the physician, the medical examiner, or the coroner who reports it on the death certificate. States register all death certificates and send them to NCHS, where they're used to produce the nation's official death statistics. Certifiers are asked to use their best medical judgment based on the available information and their expertise. When they can't make a definitive diagnosis, but the circumstances are compelling with a reasonable degree of certainty, certifiers may include the terms probable or presumed in the cause of death statement. Next slide. When COVID-19 is reported as a cause of death on the death certificate, it's coded and counted as a death due to COVID-19. COVID-19 should not be reported on the death certificate if it did not cause or contribute to the death. Next slide. Cause of death data quality is impacted by how this reporting process works. Getting high quality cause of death information can be challenging, especially during emergencies. Certifiers are faced with heavy workloads. They may not have access to complete information about the death or may not be well trained in how to prepare quality cause of death statements. The quality of cause of death data depends on death certificates being complete and accurate. So complete means describing a clear chain of events from the immediate to the underlying cause of death and reporting any other conditions that contributed to death and providing information that is specific. Accurate means reporting the correct conditions as causes of death. So this process is not perfect, but it is very useful. Next slide. So the National Center for Health Statistics does review the data and works towards improving the completeness and accuracy of the death certificate data. They monitor data quality with ongoing review of death certificates as they are received, and by following up with the state vital records offices to verify and correct inaccuracies. They also provide a suite of training and tools to help certifiers, such as online courses to improve cause of death reporting and a cause of death mobile app even. They offer death certificate reporting guidance and tailor advice to specific topics like COVID-19 to help certifiers better complete the cause of death section on the death certificate. Next slide. So here's a couple of scenarios to walk through. Scenario one, a 77-year-old male with a 10-year history of hypertension and chronic obstructive pulmonary disease presented to a local emergency department complaining of 4 days of fever, cough, and increasing shortness of breath. He reported recent exposure to a neighbor with flu-like symptoms. He stated that his wheezing was not improving with his usual bronchodilator therapy. Upon examination, he was febrile, hypoxic, and in moderate respiratory distress. His chest x-ray demonstrated hyperinflation and his arterial blood gas was consistent with severe respiratory acidosis. Testing of respiratory specimens indicated COVID-19. He was admitted to the ICU and despite aggressive treatment, he developed worsening respiratory acidosis and sustained a cardiac arrest on day 3 of admission. Next slide. So this is the death certificate for this individual. So note that the immediate cause of death entered should be acute respiratory acidosis, and the interval between the onset of that condition and death is 3 days. But the acute respiratory acidosis is considered due to COVID-19, the onset of which was 1 week prior to onset of death. In addition, under Part 2, chronic obstructive pulmonary disease and hypertension are listed as significant conditions contributing to death. Next slide. Here's a second scenario. A 34-year-old female with no significant past medical history presented to her primary care physician complaining of 6 days of fever, cough, and myalgias. She was found to be febrile, hypotensive, and hypoxic. She was admitted to the hospital and underwent a CT scan of the chest, which revealed diffuse ground glass opacification indicative of viral pneumonia. Respiratory specimens were sent for testing and RT-PCR confirmed COVID-19. Her condition deteriorated over the next 2 days and she developed acute respiratory distress syndrome, or ARDS. She was transferred to the ICU and started on positive pressure ventilation. Despite aggressive measures, she expired 2 days later. Next slide. And this is the death certificate for this scenario. So here, acute respiratory distress syndrome is listed as the immediate cause of death with interval from onset to death of 2 days. Pneumonia is the underlying cause for acute respiratory distress syndrome, and COVID-19 is the underlying cause for the pneumonia, both of which were onset 10 days prior to the date of death. In this case, because there were no significant past medical history findings, the Part 2 is left blank. Next slide. So in conclusion, timely and accurate reporting is critical to COVID-19 response because it really determines the quality of the data that we receive. If COVID-19 is determined to be a cause of death, it should be reported on the death certificate. When reporting COVID-19 as a cause of death, use the standard terminology such as coronavirus disease 2019 or COVID-19, and report pre-existing conditions that contributed to the death in part 2 of the death certificate. Next slide. So there are additional resources on the CDC website and CHS to provide additional guidance for certifying deaths specifically due to coronavirus disease 2019. For anyone who's interested, there was a COCA call held earlier this summer on guidance for certifying deaths due to coronavirus disease 2019. And these are CDC webinars that are put out that can be quite useful to watch and gain additional information. Next slide. Here are some other resources, web-based resources related to death reporting from NCHS and CDC. Next slide. And I wanted to also show our EDRS system in Hawaii, the Electronic Death Registration System. This is administered by the Hawaii Department of Health. Go ahead to the next slide. So this is the death reporting workflow. The certifier starts the case by entering cause of death in EDRS. In EDRS, the mortuary can then pick up the case started by the certifier. And in EDRS, the Department of Health approves disposition permit and can refer the case to a coroner if needed. This is an example from the EDRS system of what the certification page looks like, similar to the scenarios that I was showing earlier, but this is the actual format you would see on the screen. So the required fields are to enter date of death, time of death, whether the ME or coroner was contacted, and then the immediate cause of death is required. Now, the other underlying causes are not required fields because they may or may not exist, but please do enter them if there are underlying causes related to the immediate cause of death. This ensures that we capture all potential contributing causes of death. Next slide. And oh, don't forget to save your work, yes. So that concludes the content here. This is our website for HDOH, where you can find the data that I showed at the beginning of the talk under these different links here. So you can look at age trends, outcomes, and other data related to COVID-19. Next slide. I want to acknowledge many people. I am not an expert in death reporting, but received a lot of resources from our Office of Health Status Monitoring, from Brian Pang, as well as one of our epidemiologists who's worked on a project with OHSM for some time looking at pneumonia causes of death. There are many within Disease Outbreak Control Division who've helped compile the data that went into the presentation. And of course, our district health offices and medical examiners and county coroners have worked closely with us on death reporting throughout the epidemic. So with that, I'd like to pause and take any questions.
Thank you so much, Dr. Kemble. That was an excellent presentation, very informative. For our audience, if you could please type your questions in the chat box, I'll moderate the question and answer session for Dr. Kemble. Does anyone have questions at this time? I have one question, Dr. Kemble.
Yes.
Have many autopsies performed in Hawaii on patients with COVID-19?
Yes, there are a number of medical examiner cases for which we have to await autopsy reports.
For the audience,
I will clarify though that COVID-19 in and of itself is not an indication for autopsy. It's considered a natural cause. But there are situations where autopsy does need to be performed in a patient who had COVID-19.
Right. Okay, audience, floor is open for questions. If you could type your questions in the chat box, please. Give everybody a minute to type in their questions.
And while people are thinking, one other comment I'd like to make is this whole pandemic has really revealed how critical the flow of information is to providing timely and accurate data that's actionable for our community. It's really been a time when we really see that reality more than ever. So I think a lot of the goals going forward are to try to modernize many of the data systems within public health, within communications between healthcare settings that allow for that information to populate a related record in another system. So this is a really good example of that because while we receive information about cases, we don't necessarily receive information about their death, whereas EDRS receives information on all deaths, but may miss some of the signals related to COVID-19. So this pandemic has really been an impetus for us to work more closely with our Office of Health Status Monitoring and to look at ways to connect our electronic systems so that information flows more clearly.
We have a question that's come in, Dr. Kemble.
Mm-hmm.
Are there any regulations on how a deceased person's body needs to be managed in the nursing home? For example, how much time would how quickly would the body need to be picked up? What kind of transportation would be made, etc.?
So there's nothing specific to COVID-19 that would change, to my knowledge, that would change how the body would need to be handled. So I am not sure what the typical timelines are for that in the general setting in nursing homes, but COVID-19 shouldn't change that timeline.
And what about the transportation? Does anything special need to be done for transporting the body to the morgue?
There are no special precautions other than what would normally be taken for transporting the deceased. So, appropriate use of personal protective equipment as one would use for any death.
And the other follow-up question is, often the nursing homes, when the patient dies, they put the patient in a room and allow the family to visit. This questioner is asking, assuming no visitation by family in this type of situation.
That's a good question. I'm actually not sure of the answer to that, and that may be a question to turn back to the hospitals and what protocols they put in place. From an infection control standpoint, much of the risk of COVID-19 has to do with respiratory transmission. So once a person is deceased, that risk is far less of a concern. I think at that point, it would really be about taking appropriate precautions in terms of PPE when handling the body.
Thank you. The next question is, do we call the medical examiner for the death of a hospice patient who's positive for COVID? I'm assuming this is somebody who dies at home.
Do you call the medical examiner for a hospice patient? They would not need to be involved in that necessarily. As I said, it's not an indication necessarily for it to be a medical examiner case. So it would only be if there were some other concern.
Oh, this person was asking about the patient who was hospice with COVID-19 who died in a nursing home.
Died in a nursing home?
Yeah, would the medical examiner need to be called for that?
Again, I think unless there's another indication for the medical examiner to be called, I'm not aware of an indication based on COVID-19 for it to be a medical examiner case.
Does anyone have any other questions? Okay, well, given that there are no other questions, I wanted to thank you so much, Dr. Kemble, for joining us at our grand rounds. You've done it before, and I'm sure before this is all over, we will ask you again to come for some different topic. And we appreciate you always be willing to come to speak to us. So thank you very much and all the best.
Thank you.